Hello and good morning to everyone. And today we are going to start one more topic of neurology, that is epilepsy, epilepsy or seizure disorder. So to start with epilepsy, it's a very important topic first of all. And the important thing about this topic is that because it is very common type of condition, and a very important thing to understand is basically the difference between the seizure and the epilepsy. So, this is the outline of what we are going to discuss in this lecture and introduction. Now, as I told you, the importance of this condition, seizures or epilepsy, you know, it's a common neurological disorder, and like 50 million people worldwide, they have epilepsy. Epilepsy, not seizures, right? So, very important thing to understand. 50 million people they have epilepsy, and now the important thing, like first of all, I will go and talk about the definitions, and then I will move further. So, what is seizure? How we can define seizure? So, seizure is a short term or short period of neurological dysfunction. You can say it is transient transient neurological dysfunction. And what happens in this one, or what is the cause? Caused by excessive activity of cortical neurons. Okay, so what's going on? There is excessive activity of the neurons. What it says, cortical means like in the cortex. So what, when there is like excessive activity, so what is the result of that? So resulting in paroxysmal alteration of behavior or EEG changes. And now, see, the word here which I'm using is behavior. And why, this term is important. Why it's important to use the term behavior? Because what is the concept of seizure is, like, there should be jerky movements in the body, which is not always there. Okay, so it is not always like this, that whenever the patient have seizure, they are going to have jerky movements in the body. It could be absence seizure. Absence seizure is something in which the person is like become stunned, or it could be gustatory type of seizure. For example, uh, some of the people, when they experience seizure, what happened, like they have some altered sensations of taste or things like this, right? So it is not always jerky movements. Okay, very important thing to understand. So that's why there is change, alteration or change in the behavior, or changes in the EEG, which is electroencephalogram. Okay, so now we are discussing about seizure. Uh, you know what is the most common of seizure in human body? It is stroke. Stroke is the most common cause of seizures, or you can say late onset seizures, uh, the seizures which occur in old age. So the seizures can be a result of acute trauma or insult to the brain. Okay. Uh, Now, this is also very important. It could be due to alcohol. Okay. It could be due to drugs of abuse, like cocaine. Okay, they may have like drugs of abuse. They give what you can say seizures. So drug of abuse, it could be drug of abuse, or it could be a withdrawal from that drug. So many people, when they stop taking that drugs, okay, they may experience seizure. So it could be acute insult to the brain, alcohol, drugs of abuse, withdrawal. Uh, it could be due to tumor. It could be due to trauma. It could be due to vascular event like stroke. Okay. It could be due to CNS infection. You know what are the CNS infections? For example, meningitis or encephalitis. Okay, so it could be due to that even. So see, there are many causes of seizure, you can say, and there are many. For example, metabolic causes, guys. Like I always stress on this thing. Remember, any type of metabolic problem can cause seizure, which could be hypoglycemia, which could be hyponatremia, hypernatremia, any type of electrolyte. Okay, so simply I will write electrolytes abnormality. Okay, or like imbalance. Simply they can give seizure. Okay, so electrolyte abnormality can be there. Okay, and as well as what you can say. uh, So see, electrolyte abnormalities can occur in liver conditions. Electrolyte abnormalities can occur in kidney or renal failure. So all these things, can cause what you can say seizures. You can add over here medications as well, because many of the medications can give seizure as well. So medications, drug of abuse, and their withdrawal, all of them they can cause seizures. Okay. Uh, so see, seizures can be caused by multiple conditions. And again, I'm stressing again, we are just discussing seizure, which is a short episode of behavior change, right? And the last point I would like to add here is, uh, or it could be a, manifestation of epilepsy. Okay. Now, when I said like it could be a manifestation of epilepsy, then we should discuss what is epilepsy, right? I hope you understand, guys. Uh, like, see, there are a lot of causes of seizures, right? So now I will discuss what is epilepsy. Epilepsy, right? So, what is epilepsy? See, it's a chronic condition, first of all. Seizure is a short episode characterized by two or more unprovoked seizures. Okay, so now anyone who have two or more than two unprovoked seizures, okay, unprovoked seizures, we call it as epilepsy, or underlying predisposition, okay, to seizures in a patient who already had at least one seizure. Okay, so see, anyone who have two or more than two unprovoked seizures, it is called as epilepsy. Anyone who have one seizure but he is at risk or he is predisposed to get one more seizure will also be called as epilepsy, right? So now, like many people, they confuse this thing. Many people, they confuse epilepsy with seizures, right? Epilepsy is you can say seizure is a type of sign or symptom, right? Whereas epilepsy is a disorder. Okay, so simply, epilepsy is when two or more than two unprovoked seizure, or one with predisposition, like any patient who is at risk of getting more seizures, we name them as epilepsy. Okay. uh, and see, that's the reason when the patients, they are epileptic, in most of them we don't know the cause. What is the cause of epilepsy? We don't know. Okay. So simply the cause of the epilepsy in most of the patients is not known. Okay. uh, so now, the important thing, like, see, like, epilepsy is what you can say a very, very, very uh, common thing in neurology, you can say. Okay. So this thing, if you understand what is the difference between a seizure and epilepsy, of course. Okay. So simply, when we classify seizures, by the way, um, when we classify seizures, we can also classify them on this basis, like provoked and unprovoked seizures, right? So provoked seizures are due to, for example, low blood sugar, alcohol withdrawal, any electrolyte abnormality, due to infection, due to trauma. Okay. uh, and unprovoked seizures are basically uh, anything without a known, or without a known, you can say, onsetting thing, right? We don't know when the patient is going to get a seizure, right? So this thing. So etiology of the patients, who have epilepsy, number one is genetic. Okay. And that's the reason, I wrote it on the top of the list, because whenever we are going to take the history in any patient, and we want to see either there is higher chances of getting epilepsy or not, so we always ask, anyone in the family have this seizures. Okay. Because if they will say that yes, someone in the family, they do have seizures, so the chances of getting epilepsy is very, very, very high, right? So it could be structural. Okay. So when we say structural, it could be any anatomical problem, or which is interfering with the normal anatomy, like it could be stroke, it could be infection. Okay. And it could be a tumor, or it could be some malformation. Okay. uh, Anything like this, or it could be a neuro degenerative condition. Of course, like, what are those? When we'll discuss more neurology, we are going to discuss about that, and unknown causes, right? And many of the time, we don't know the cause, of course. So that's why unknown causes makes a very, very, very important part in this one, right? So hopes you understand the difference between the definition of seizure and epilepsy. And again, like, the same definition is written, but a little long one. The clinical manifestation of normal hypersynchronized discharge in a population of cortical excitatory neurons. The discharge may result in. So see, I use a word abnormal behavior, but here they say loss of consciousness, altered perception, impairment of psychic function, convulsive movements, disturbance of sensation, some combination of these things. And epilepsy is a tendency towards recurrent seizures unprovoked by acute systemic or neurological insult. Okay. So now the classification. So we can classify epilepsy, we can classify seizure. Rather, I would like to discuss you can see the epidemiology in front of you. I'm not talking about that, these things will take a lot of time. And so I would like to classify seizures. Okay. So here a lot of, you can say, a little complicated type of classification is written. Rather, I would go for a easy one. So what is the classification of seizures? uh, so again, classification, I again, I always say that, it is just to make the things easy, guys. Okay, to remember the things. So whenever there is seizures, remember, they can be what? Provoked. They could be unprovoked, right? Which we already discussed. And whenever there is provoked seizures, guys, what can be the cause? In babies, in pediatrics, uh, what I will teach you is a febrile fits. Okay, very 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 important. And febrile fits means what, which occurs due to fever. So that makes a very important part of provoked one, because in pediatrics that's a very common cause. It could be due to trauma. Many people while playing that, for example, if a ball hit your head, and many people they have a seizure after that. So of course that's an example of provoked feature. Or it could be metabolic, for example, someone who have hypoglycemia or hyponatremia or hypernatremia. So all these causes, which we have already discussed, like here, uh, okay, like of course they can all cause what you can say provoked seizures. And whenever it comes to unprovoked, guys, so unprovoked seizures, uh, or you can say epilepsy, or recurrent unprovoked seizures is also called as epilepsy, right? So here we will talk about, we can write in the bracket like it is epilepsy or epileptic seizures, you can say. Uh, see, uh, now one thing, they could be partial, okay, and second thing, they could be generalized. Now, what is partial and what is generalized? It's very 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 simple. I don't know like why people uh, they think like this one is hard, um, but though it is not hard at all. Uh, Partial seizures are simple seizures which are um, to one area, or which is giving, you can say, some focal type of symptoms. Okay, so basically this is an older name. Nowadays we call them as focal seizures. So what is focal seizures? When, for example, someone have seizures just in hand, or just in feet, or just in tongue, or just in eyes. So see, a simple uh, one area, or one system is affected, right? Nothing more than that. Okay, so we call it as focal seizure, which means that um, it is like some specific part of the brain is hyper firing, okay, or firing simply. And the other one is generalized. Generalized means like when the seizure become generalized all over the body. One thing, guys, remember, partial seizures can change into generalized. Okay, so uh, partial can become generalized. Okay, as well. Okay, so now one more thing, guys. See, seizure can be a simple seizure. Partial seizure can be a complex seizure. Okay. Same thing with generalized. Generalized seizure can be convulsive. Okay, and generalized seizure can be non-convulsive. Convulsive. Okay. And now what is what you can say simple and complex? Uh, Again, very 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 easy to understand. This thing is simply when someone during seizure is maintaining uh, their consciousness. Okay, like someone have seizures but he's conscious, we call it as simple. Whenever the consciousness is impaired, we call it as complex, right? So see, a simple means what? um, Consciousness, okay, and consciousness is impaired, okay, and uh, complex is what? When uh, cons- consciousness is, sorry, simple is not impaired. Okay, is not impaired. Someone who know like what's going on, and when the consciousness is impaired, we call it complex, right? So this is a very very easy thing to remember. Simple is like when consciousness is impaired, is not impaired, and complex is when the consciousness is impaired, right? And convulsive and non-convulsive, guys, see, what you see in the movies when someone have epilepsy, uh, they fall down on the floor and they start jerking their body. That is convulsions. Okay, so that is a convulsive type. And non-convulsive is what? Um, when like someone who don't have that, what we call in simple language as fits. Okay, when someone don't have that fits, simply we call it as that. Uh, we call it as um, it is non-convulsive. Okay, so now one more thing. See, uh, partial, what it means, like partial, it could be simple or complex, and generalized, it could be convulsive and non-convulsive. Uh, okay, simple partial seizures can be motor, can be sensory, can be um, autonomic, can be psychiatric. Okay, so simple, see, simple focal is the new one, partial is the old name. Simple focal motor seizure, what it means, there will be some motor manifestation you will see. Simple focal sensory type of it means what? Maybe the person will feel some abnormal sensation in some part of the body. Same thing with autonomic, okay, and like this. Whereas non-convulsive, okay, one of the example for non-convulsive is absent seizures. Okay, I will discuss this one later. Okay, many people they have like kids they have. Okay, okay, convulsive can be clonic, can be tonic, can be clonic tonic, or tonic clonic. You can say anything. Can be tonic, clonic. Okay, can be myoclonic, and can be atonic. Okay, see, convulsions is going on. Okay, there is some jerky movements. So what is clonic, what is tonic, what is tonic clonic, what is myoclonic? See, tonic means what? When the tone is increased, that is means like muscle contraction is there. Okay, so what happens in these patients, uh, the one who have tonic seizures, their muscles become contracted. Okay, their muscles become stiff. They take some abnormal posturing, right? So that is called as tonic. And then what is clonic means? Clonic means, jerks. So someone who have jerky movements. Okay, that's what they show in the movies, by the way. In Hollywood, what they show, or in Bollywood especially, what they show is like when someone fall down on the floor or on the ground and they started jerking their body. So that is clonic type. Tonic means what? The muscles will go into contraction and stay like that. And tonic clonic means what? Both. The muscles will be jerky as well as it becomes stiff or become contracted. Myoclonic, simply, what is myo, guys? Myo means muscle, and clonic means what? Clonic means jerky movements, right? So myoclonic means what? That in this one you are going to see the different muscles, myo muscles, will go into jerky movements. Okay, because it is myoclonic, so muscles will go into jerky movements. Okay, it is not myotonic, it is myoclonic. And what is atonic? The tone will be lost, right? So this is to how we classify uh, seizures. Okay, and now uh, see, one simple classification is written over here: generalized seizures or partial focal seizures. Okay, it could be tonic clonic or tonic clonic. Okay, now this is very important, guys, because in many of the books you will find the same things written. Okay, and maybe you will be confused, like I didn't maybe talk about that. But basically, there are different names for different type of seizures. For example, absent seizures. Okay, mm, I have to find. Okay, it will come on the way. Okay, for example, tonic clonic seizures are also called as grand mal seizures. Okay, tonic clonic seizures are also called as grand mal seizures. Okay, uh, absent seizures. Okay, it is the second one. Okay, absent seizures are also called as petit mal. Okay, so tonic clonic is called as grand mal. Okay, this thing, remember. and absent seizures are also called as petit mal. So in the books, many of the books, they still use the same time, same type, you can say, of things. So generalized seizures can be grand mal, can be petit mal, can be myoclonic, okay, can be clonic, can be tonic, can be atonic, okay. So all this one. There is juvenile myoclonic epilepsy. There is Lennox-Gastaut syndrome. This Lennox-Gastaut syndrome, I will see like if we'll discuss in this one, but in pediatric for sure we are going to discuss. Okay, and then when it comes to the partial seizures, it could be simple, it could be complex. I told you it depends on the consciousness, either it is maintained or not. And there is number third is um, you can say unclassified epileptic syndromes or uh, special epileptic syndromes. Of course, like this one will not be our discussion in this one. Okay, so clinical features, guys. Like see, like they are showing, in focal one, just one of the areas over firing, but in generalized, of course, many of the areas are over firing. Okay, so again, we have discussed this thing, right? But I'm just scrolling down. You can stop the video and of course like take a look what they're talking about. Okay, this is what they're showing is a typical clonic tonic epilepsy. See, in tonic phase, what's going on? Loss of consciousness. There is tonic contraction. There is no breathing, and the cyanosis can be there less than a minute. Then clonic phase, like still unconscious, convulsive movements will be there. Self-injury can be there, like tongue biting or things like this. Incontinence, irregular breathing, cyanosis, and then there is a coma phase. They become unconscious, flaccid, regular breathing, and color improves in that one. Okay, guys, what I will be talking about is a little more in detail. When we have discussed already the classification, right? If I will talk about the clinical features, okay, uh, clinical features, I will be talking about like about them, like I just now you had one example, right? How the clinical features basically they behave, right? But here, what we are going to discuss is uh, I don't know what's wrong with this, but it's okay. We are going to fix it now. Um, okay, so I know what's wrong. Okay, so guys, like in clinical features, there are many things to talk about, but like quickly, I will tell you, for example, how a partial, what you can say, a person who have partial seizures uh, will be presenting. Partial seizures means what? Focal seizures. See, partial seizures can be simple, can be complex, right? And one of the things, partial seizures can change into what? I told you already, generalized seizures. Partial seizures can become generalized, and we call it as partial second generalized seizures. Okay, uh, we can simply say that simple or complex can secondarily generalize, right? So it goes like simply this way, that there is a simple type of seizure, and then what happens, like it will change into complex type of seizure, like they are going to lose their consciousness, and then what will happen, it will become a generalized seizure, right? So seizure, right? So partial seizure or simple seizure uh, can be sorry, focal partial seizure or focal seizure. I would write rather here focal. Okay, focal seizure can be simple, can be complex, right? I think very easy concept, right? There is nothing big science in this one, right? It could be simple and it could be complex. So if I will talk about the simple, as I told you, simple can be motor. For example, the person can present with um, some turning of the head, turning of the eyes, some jerking movements in one of the limb. Okay. uh, what you can say when what you can say when when the jerking from one muscle group basically move to the other muscle group, we call it as Jacksonian march. Okay. So this is one of the thing. So see, simple focal seizure can be motor, can be sensory. And sensory, for example, the person will be having some altered vision, some altered smell, some altered touch sensations, anything like this thing. Simple seizure, again, if you're confused what I'm talking about, I already told you the classification, right? I already told you how we classify, and what we are going to do, what I am doing, by the way, right now is simply I'm talking about um, how the motor will present. Okay. Motor will present, how the sensory will present, how the autonomic will present. uh, Autonomic partial seizures can be, for example, think about the autonomic functions in the body. It could be sweating, flushing, you know, piloerection. The hairs, small hairs can become erected. Okay. And it could be psychiatric. For example, the person have some uh, symptoms, psychiatrical symptoms simply, right? It could be like this thing. And uh, partial or focal complex seizures, uh, of course, their awareness will be lost. Okay. The person uh, will be uh, unaware what's going on around. It's not like this, like the eyes should be closed, but simply uh, the person is basically unaware of what's going on around him, right? So what will happen in these patients? The persons, they become unaware of surroundings. They don't know what's going on around them simply. Okay. So uh, now what happens in these patients, many of these patients, they have uh, like what we call it as, um, there is a term called as automatism. Okay. Auto um, automatism. So what is automatism? It is basically chewing, swallowing, or lip smacking movements. Okay. Sometimes fumbling or things like this. Okay. Certain these kind of movements, we call them as automatism. Okay. And many people, who have this complex seizure, they can have a feeling. I don't know, like how you are familiar from these terms. Deja vu. Like, they have some, like, uh, out of the body experiences, right? Or they feel something uh, which is not in their memory before, things like this, right? Sometimes, they have a features like uh, cognitive features, like disoriented. They become disoriented, right? And many of the people, complex seizures are very, very, very different type of seizure. Many of the patients, they have hallucinations. Okay, hallucinations. Okay. Many of the people, they may have, okay, they may have hallucination of smell, taste, vision, any type of hallucinations can be there. Okay. So this is how complex seizure patient present. And the other one, which I talk about, is the generalized one, right? Generalized. So in generalized seizure, what I told you, generalized can be uh, convulsive and non-convulsive. And non-convulsive one is which one? Absent seizure, right? So absent seizure. So what is the other name of absent seizure? It is also called as petit mal, right? And now this one, absent seizure, is basically usually seen in children. Okay. This one is usually seen in children. And what happens in the children? Basically, they become unresponsive for a few seconds, like 5 to 10 seconds, right? Like they become unresponsive. They don't do anything. And what happened in them? Like they started staring at something. Okay. without knowing what's going on around them. Okay, some of the children, they blink also during that time, so they show some blinking movements. Okay, blinking of the eyes. Some of the babies, they show eye rolling, for example. Okay, things like this. One of the thing, guys, when we do EEG in patients, in these patients, we found 3 hertz spike and slow wave activity. By the way, it's a very, very, very important point to remember, because it comes on many of the MCQs. And like, you will found that they had done a EEG, and what they found, like, the child is showing, like, the brain is showing this one, a 3 hertz spike and wave activity. So this is very typical for absence seizures. Then I told you what is clonic one, right? So what is clonic? Simply, uh, sorry, okay, okay, wait. Clonic. Okay, so what is clonic one? Clonic is, guys, simply, uh, these are those, who have rhythmic movements of the body. And then I told you what is tonic. Like, simply, there is muscle stiffness or rigidity. Okay, it could be in flexion or extension, like there's a different body posturing. And one thing is, tonic clonic, and which is which one? Which is basically also called as grand mal. So absence seizure is called as petit mal, and tonic clonic is called as grand mal. One very important thing, guys, whenever we take history of seizures, okay, uh, very, very, very important point. Always ask from the patient. Always ask uh, what what happened before, during, and after. Why? Because, see, uh, there are many conditions, uh, which, what you can say, looks like, what you can say, um, epilepsy, but or seizure, but they are not basically seizure. For example, syncope. For example, see someone who have hypoglycemia, right? Uh, they become confused. They fell down on the floor, and there are typical symptoms which we ask, and there are typical signs which we see. For example, the people who have hypoglycemia, they started having jerky movements, sorry, like shaky feeling, because of symptomatic activation. Sympathetic nervous system, it become activated. They become sweaty. uh, they feel energy drained, and then they fall down. Okay, uh, so the important thing here, uh, for example, a patient came to you, and he will say that, doctor, I was like, mm, standing, and suddenly, I feel shaky, I feel sweaty, and then I fall on the ground, and after some time, I regain my consciousness, and I was feeling fresh. So uh, for example, someone has syncope, for example, uh, due to vasovagal syncope, or like decreased blood supply to the brain, they can fall down on the floor. And people, they pick up their legs just to increase more blood supply to the brain, and then they regain their consciousness. Very common in soldiers, when they are standing for a long time for parades and things like this. So uh, basically, uh, the people who have epilepsy, many of them, before us having epileptic fit, they have a aura. Okay, they have some altered feelings, they have some, uh, sometimes they know some provoking factor, like flashes of light or loud sound, and then they uh, started fitting. Okay, so before, always ask about the aura symptoms. uh, During, remember, most of the patients, who have epilepsy, by the way, they don't remember what happened, because they have the complex type of seizure. So always take a parallel history from someone who is the observer. So a true epileptic patient, they show some features like tongue biting. They become urinary incontinent. They like they urinate, or they defecate. Okay, uh, and the jerky movements. they stay for a while. For example, in jails, many of the people who are in jail, they mimic epilepsy or seizures, but they don't have. By the way, there is a way to catch them as well. I will let you know. And always ask after, uh, because most of the patients, who have the real the seizures, by the way, after regaining their consciousness, they are not fresh like normal people. Rather, you can say they stay confused or they feel tired, okay, and many of the time the people they sleep, okay. So very important during the history to differentiate the other differential diagnosis. Always ask what happened before, during, and after the seizure, right? It's very, very, very important. So generalized one, tonic clonic, I told you. Then there is one more type, which is myoclonic, right? Myoclonic type is there. So myoclonic type is there, which I told you already. Like muscle groups, they basically started, what you can say, uh, contracting, okay. And then there is atonic, simply muscle tone is lost, okay, and they have the drop attack. So these are the clinical features of epilepsy. Now, uh, there is something called as temporal lobe epilepsy. So now temporal lobe, there are many centers, like your olfactory center is there, your gustatory center is there. So simply temporal lobe epilepsy is suggested when the people, they have an aura. Basically in that aura, they get feared, okay, they feel really scared of few of the things around them. And then they have hallucinations, or they may have hallucinations of, what you can say, olfactory or gustatory type, okay. Sometimes they do have deja vu sensation as well. So uh, whenever we found these typical features, we say that the patient have temporal lobe epilepsy. For example, someone who have a frontoparietal cortex seizures, what happens, like their contralateral sensory and motor signs will appear in them. As I already talked about in the discussion about the centers. For example, someone, the motor and the sensory cortex have the seizures. So of course they will have the sign and symptoms in the opposite side of the body, according to the brain, the part of the brain which controls them. Uh, now, uh, see, okay, of course, like after this, we are going to discuss the treatment, right? Uh, so I told you about what is syncope and what is seizure and what is pseudo seizure, right? So, there are many things, which looks like seizure. It could be syncope, it could be a pseudo seizure, it could be hyper panic attack, it could be transient ischemic attack, it could be hypoglycemia, it could be alcohol blackout. Many people, who drink alcohol too much, they become blackout. It could be migraine, by the way. So there are many things which can mimic like seizures, right? So uh, by the way, I wanted to show you this thing, very important, guys. This is the generalized 3 hertz spike and wave discharge in a child with absent seizures, right? Um, so again, like I'm just scrolling it down, okay, and here it says, first aid for tonic-clonic seizure. Turn the patient on side and face down towards the ground to keep airway clear. Transfer to hospital and do not put any object in the mouth, right? So I already explained you these things, but again, like I'm just scrolling down the slides. This is what I was talking about, temporal lobe epilepsy. They have like gustatory or auditory hallucinations, and uh, these are different. Okay, these syndromes I'm not talking about right now, because we are going to talk about them in um, uh, pediatrics, right? All these syndromes are basically pediatrics part, not here. Okay, guys. So investigations, um, um, now, you know, um, it's very difficult, you can say, sometimes, to diagnose uh, what is the cause of. For example, if you have a patient, and he have a seizure, just one episode, can you label them epilepsy? No, on one we cannot. But if someone who have one and they are predisposed to get more, of course we can start them on epileptic drugs and we can label them as epileptic. But of course on one seizure we don't go for that. Okay, so when by the way, any patient who come with a seizure, first of all in history, we try to catch either it was a real seizure or it was something else, that differential diagnosis. So always take a parallel history from an eyewitness, right? And it's a very important diagnostic test, you can say, because we will ask the person how he was behaving, what he was doing, what was his body movement, so on and so forth. Very, very, very important. Then we do a physical examination. Okay, in history you will ask like either he was incontinent for urine, feces, tongue bites. Okay, what happened before, during, and after. Either he was conscious, either he was confused, either he was drowsy, either he slept, and what, so on and so forth. Then we do a physical examination where we see the signs. In physical examination, by the way, a very important thing, which I would suggest you, if the person have or what you can say, a history of fall, during seizure, always check the neurology. Always check if he have hit on the head. Okay, then we go for the blood examination, CBC, electrolytes. We can do glucose, we can do calcium, magnesium, ESR for infections, liver enzymes, creatine kinase. Creatine kinase is very important. Why? Uh, because when the muscles will go in too much uh, stiff contraction, creatine, there will be muscle breakdown and creatine kinase will raise. A very important test to catch someone who was basically uh, mimicking or fabricating a seizure. Okay, happen in prisons, by the way. uh, we can measure the prolactin level. Very, very, very important test to catch anyone either who had a seizure, who had a real seizure, or who don't have a real seizure, right? So checking prolactin levels are very important in this one. Okay, so once we go for we check the prolactin levels, we like the story become clear that either the patient had a epileptic seizure, or uh, you can say the patient was just uh, you can say just fabricating one. Okay, so anyone who have a high prolactin level, or what you can say, after a seizure, okay, uh, it means like he have what you can say, a real seizure. Okay, so prolactin levels are very important. Okay, so someone who is like having a psychogenic type of seizure, or someone who was fabricating a seizure, of course their prolactin levels will be normal. Okay, so this thing, guys, always go for a toxicology screen, right? uh, we go for a toxicology screen, uh, especially alcohol levels, right? Alcohol levels can uh, check the levels of anti-epileptic drugs. AED here is anti-epileptic drugs. Okay, uh, why this is important? Because many times the seizures, they occur in the people mm, who are already taking drugs for their epilepsy, and because they miss some dose, or they do things like this, that they like either the epileptic drug is not working well. So basically we check their levels as well. So of course for first diagnosis we have to rule out all the features or all the things which can be a cause of provoke seizure. So we go for different investigations. We go for the blood test, we can do a lumbar puncture if we are suspecting meningitis or encephalitis. We can do a toxicology screen. We for sure will go for the imagings like CT scan, MRI. Okay, because see the tumors, trauma, um, even stroke can be catch on that, and we will go for EEG. So of course, like depending on if the patient have one seizure, you are going to do this investigations for diagnosis. Okay, so. Uh, EEG findings, like they are suggestive of the EEGs, like EEG findings which are suggestive of, we can say, epilepsy are many. For example, if you found abnormal spikes, or uh, spikes, or spike and wave patterns, it means like there is some abnormal EEG patterns which are there, and we can diagnose the patient on that. Okay, so uh, questions raised by the first seizure or not provoked, seizure type, either it's focal or generalized, it's evidence of CNS dysfunction syndrome, which studies should be obtained, should treatment be started, which drugs should be used. Okay, of course, like if someone have one provoked seizure, we don't start any drug. But if someone have what you can say multiple seizures, okay, or if they are predisposed to getting more seizures, of course we start the drugs, right? uh, okay. uh, 60% of the times it happens by the up to 60% of the times you can say it happens that the EEG come back as positive, right? But some of the time it's not like this, that the EEG will come back as positive on the first time. Rather, sometimes we have to do multiple EEGs. Okay, and guys, remember, a normal EEG or electroencephalogram can never, what I'm saying, a normal EEG or electroencephalogram cannot or can never rule out epilepsy. Okay, this is very important uh, point to remember. So, difference between a syncope and a seizure. Of course, like, you can stop here, you can take a look. This is a slide, guys. I can make mistakes. Okay, now, I'm sorry. Treatment of epilepsy. First of all, we on the history we found, or we try to sort out either the patient have any provocative factor or not. Because if they have, for example, someone have seizures due to um, bright lights, you can say. Okay, so we simply ask them to avoid that. So the first thing is um, uh, avoid any any precipitating precipitating you can say factors, right? Loud noises, flashes of light, and all this stuff. So uh, you can say acute management. Of course, that's a different thing. For example, there is a condition called a status epilepticus. What you have to do when someone is uh, fitting in front of you, right? That's a different thing. But what we are going to discuss now is long-term management, of course. In the first thing, when we have to give anti-epileptic medications are very important. Guys, remember, when someone have two or more than two unprovoked seizures, okay, uh, someone who have known organic brain disease, someone whose EEG is showing some abnormal activity, okay, we have to start with them with the drugs, right? So uh, we educate the persons what is this condition. We ask them in what you can say, different countries have different type of what you can say guidelines. We educate the mothers, we educate the patients, we ask them to don't swim alone, don't do some jobs like which are near dangerous machines or heavy machines. um, for example, some mother who is feeding her baby, don't feed the baby on the chairs, always sit on the ground or on the floor, then uh, feed them. So a very important part is education. Okay, we ask them to avoid swimming alone. I already talk about that thing, and all the dangers. Okay, and driving is very, very, very important. We tell them to ask or to tell their ministry or DVLA. Okay, in UK, America, Australia, it is DVLA. Okay, why? Because in most of the countries, in by the way, in all the developed world, the person's license is cancelled, by the way, or suspended. Cancelled is the wrong word. Yes, cancelled is the correct word. If we will talk about the commercial drivers, their license is taken back. They cannot drive anymore. But someone who have a fit, and uh, they cannot drive, and different countries have different guidelines. Some say like for 6 months seizure free is important. Some say for 1 year seizure free time should be important, right? uh, so very important. If the patient is not telling the DVLA, it's your duty to tell the DVLA. Okay, so always do that. uh, and we put them on anti-epileptic drugs. So, and now, guys, drugs are many. There are many, many, many drugs, right? Now I will just tell you few points, and I hope like you can remember them. See, sodium valproate is there, lamotrigine is there, levitracetone is there, topiramate is there, carbamazepine is there, phenytoin is there, pregabalin is there, gabapentin is there. I can take ethosuximide is there. There are a lot of drugs, right? All of them, they are called as AEDs. See, first of all, we put the patient on one drug. Okay, we see what is the response. If the person is seizures are controlled on one drug, we maintain their dose. If the patient epilepsy is not controlled on one drug, then we change the drug. Okay, and if the epilepsy cannot be controlled on one drug, then we give combination of two drugs, right? So uh, the most common drug which are okay, there are some in the things like this. For example, we don't give phenytoin to the females because one of the side effect of that drug is uh, like their gums become hypertrophy, gingival hypertrophy is there. Okay, so of course that drug is not what you can say used in these patients. Okay, so see, monotherapy is tried first. If monotherapy fails, then we go for polytherapy. Okay, so uh, give the dosages in increasing power, try to maintain them at some level, and when you are winning them off, taper the drugs slowly. See, all these drugs are available, right? One thing you have to remember, guys, the drug of choice for absence seizure is ethosuximide. What is the drug of choice for absence seizures? Ethosuximide. Ethosuximide. Okay, remember, this is very important. I will tell you just one thing. If you will remember that, your life will become easy. For any type of epilepsy, first drug should be sodium valproate. If someone is not responding to that, then choose carbamazepine. By the way, uh, there is the choosing of anti-epileptic drug. There are many things: cost, efficacy, adverse side effects. Okay, I was talking about phenytoin. It is the most effective, but we don't give it to young ladies. Why? Because it causes gingival hyperplasia, it causes hypertrichosis, it causes facial skin coarsening. So see, valproic acid, first choice for myoclonic. Hepatic dysfunction we cannot give. Side effect, hepatic damage. Carbamazepine, it is very good for focal. Side effects, bone marrow suppression, SLE-like reaction. So every drug have some of the side effects, okay, you can say. But first we try for monotherapy and then we go for combination of the drug. So see, if you will pay attention on this one, we can give sodium valproate as a first line drug for everyone. Whenever it fails, we can go for second line drugs. Guys, remember the drug of choice for absence seizure, it is ethosuximide. Okay, the drug of choice for absence seizure is ethosuximide. Okay, so okay, one thing is called as status epilepticus. Okay, now status epilepticus, before I used to teach here uh, in with epilepsy, but status epilepticus I am going to teach you in detail in emergency medicine, right? But what is status epilepticus? Simply unremitting seizure, or when the seizures are there and they are not stopping. Okay, it is for more than 5 minutes, more than 5 minutes of continuity. Okay, we call that thing as status epilepticus. Now, guys, you know how to treat these patients. I will just take 2 minutes to talk about that, and remember, I can ask questions about that one in the exams. Whenever someone has seizure for so long, they may have any complications like cerebral ischemia, arrhythmias, cardiac arrest, renal failure, asphyxia, anything can occur. We go by ABC, okay? Airway, breathing, circulation. We do all the investigations. We attach all the monitors. We take all the labs. Okay, but the most common cause of status epilepticus is someone who is on medication, diagnosed patient of epilepsy, taking medication, and now stop taking medications. Okay, whenever we found any patient with status epilepticus, what we do is, it's a medical emergency. All the things I talk about, ABC, initial assessment. The first drug we give to them is lorazepam or diazepam. If cannot be controlled by that, we give the patients phosphophenytoin or phenytoin. Anyone can be given. If cannot be controlled by these drugs, give the patients, okay, before that, if the thing cannot be controlled by this one, um, so this is for immediate suppression, this is for initiation or reloading, give the patients phenobarbital, okay, 1000 to 5000 milligram IV slowly. Okay, you can give it for 1 to 2 hours. Okay, if this one cannot control the seizures, then the last choice is simply midazolam or propofol or thiopental or phenobarbital. Again, the same things. Why? Because this one is to induce anesthesia. Okay, so we put the patients on continuous midazolam or propofol, okay, because this one is to induce anesthesia. So this is how we treat a patient of status epilepticus. Okay, so that's all, guys. uh, Thank you so much for listening, and I hope you understand what you can say epilepsy. See you in the next lecture.